Good morning, Dr. Misha from Jana Surgery. So our HOD asked us to do a video presentation on examination of thyroid and as well as about the probable practical discussions for a case of thyroid swelling. No, just to help you to understand how to go about examination as well as to help you through the practicals as well as the viva of your final MBBS examinations. Now, unfortunately, your posting had to be cut short, but then we are trying to compensate that clinical posting by whatever possible methods. So, I'll straight away go into the examination of thyroid, starting from history of case of a thyroid swelling. So I think majority of you might have might have come to general surgery department for the posting. So majority of you would be knowing about. Also in your third sem and seventh sem, I think we have met before. So like any examination of swelling or any case of swelling, thyroid swelling also, the purpose of physical examination is at the end of history taking, you should have an idea like what you are going to examine. You and also the person who is hearing your presentation should have an idea of what you are going to examine. And by your physical examination, you are either confirming your diagnosis by physical examination or ruling out whatever diagnosis you had in mind by the end of the history by physical examination. So that is the purpose of examination. You take history, you have some idea in your mind, and then you go about with physical examination. You either confirm your diagnosis by physical examination or rule out your diagnosis, or you form a list of differentials at the end of physical examination. Now, for thyroid swelling, generally, when you say about the diagnosis, being a swelling, there are certain things that you have to be careful. First of all, you should make the first part of the diagnosis for a thyroid swelling is about the anatomy. Anatomy means from which organ. So this is a thyroid swelling by examination. And then the pathology. Pathology, is it benign swelling? Is it malignant swelling? About the nature of the swelling. Is it diffuse? Is it solitary? Is it multinodular? Then what about the functional status, whether it is euthyroid, hypo, hyper, or any other complications are there. So all these aspects should come in the final diagnosis as far as thyroid swelling examination is concerned. Now, as everybody might be knowing, examination of a swelling in history, for any swelling, it starts with onset, progression, associated symptoms. So you ask about the onset, the progression and associated symptoms. The onset is usually spontaneous. There won't be any history of trauma or anything as far as the thyroid swelling concerned. Either noticed by the patient or somebody else, the bystander or a friend or someone else have noticed and told the patient that you have a swelling in front of the neck. So that is how usually the onset is. So once noticed, then the progression. Majority of the swellings are slow growing. It takes years for the thyroid swelling to grow, but you definitely ask for history of any recent increase in size. History of a recent increase in size you get for in a thyroid swelling whenever there is a one possibility is a malignancy. Malignancy of the thyroid, as far as thyroid is concerned, again malignancy is not a fast growing malignancy, it is a slow growing tumor. Papillary carcinoma is the commonest thyroid cancer. So papillary cancer is a slow growing cancer. So you won't get like a 1 week, 2 weeks duration history for a thyroid cancer. It could be months, like a 5-year duration swelling, last 2 months it has started growing. So like that, or 6 months or 3-4 months. So like that, it will be not a rapid increase. It will be but a swelling which was remaining there has started growing in size, or a swelling which was noticed 3 months or 4 months in duration. So some kind of a progression can be there when you suspect a malignant transformation. Suppose somebody says that I had a swelling for 10 years and now last 2 months it is painful and it has started increasing size. So all increase in size need not be malignancy. It could also be a cyst which has undergone a cystic degeneration, a nodule which has undergone a cystic degeneration, or a hemorrhage into a nodule. Hemorrhage into a nodule also can have bleeding, can have pain as one of the complications. So if you find These recent increase in size associated with pain or discomfort, it need not be always malignancy. It can be a pre-existing nodule undergoing a cystic degeneration or a bleeding into the nodule. Then sometimes, very rarely, you will get swellings with a very rapid, maybe 2 weeks duration, 2 to 3 weeks or a month duration increase in size. So suppose you see a big thyroid swelling which has occurred, which has happened or which has increased over the last 1 month. There are only two differentials that you consider. So one is a anaplastic cancer, or which is a very aggressive tumor of the thyroid, anaplastic cancer of the thyroid. Second one is a lymphoma of the thyroid. So these are the two situations where you get, like a breast cancer or other malignancies, a very rapid increase in size of its swelling. So one is anaplastic, the other one is lymphoma. Otherwise, most of the thyroid malignancies are slow growing tumors. So that is what you have to look for in progress. So usually benign thyroid swelling will take years to progress. If there is a recent increase in size of a swelling, it could be a malignant transformation. Now, very recent increase in size and a large size, it could be an anaplastic carcinoma or a lymphoma. Again, these occur in the elderly, like you see 60 or 70 years of age group. Thyroids usually you see in middle age, not very young, especially like after 30, 40, more in females. So all these aspects you have to consider. So that is one about progression. And rarely you see, sometimes the swelling can even sometimes decrease in size. A 10-year duration swelling in the natural history of a benign thyroid goiter, it undergoes involution after some time. So you might notice that, or the patient might notice that the swelling is slightly less in size compared to like where it was 2 years or 5 years ago. So that is also a possibility. Underlying process of thyroiditis. Thyroiditis also, it can resolve after a period of time. It can also kind of decrease in size after a certain period of time. So these are the things that you have to look for in onset as well as the progression of a thyroid swelling. Now then, next thing is you have to ask about any associated symptoms. Associated symptoms of thyroid are particularly the pressure symptoms. So thyroid has, underneath the thyroid you have the trachea is there, esophagus is there, and the vertebral column is there. So trachea and the esophagus can get pressed between an enlarging thyroid and the vertebral column. So first, patient might notice esophageal compression symptoms more than a tracheal compression symptom, because trachea has got a cartilaginous framework, esophagus doesn't have. So you might get esophageal compression symptoms more than a tracheal compression symptoms for a large thyroid swelling or a malignancy which is almost encircling the thyroid. Usually small benign goiters do not cause much of a compression symptoms. Now considering, when you consider the compression symptoms, the first thing that patient might complain, they may not complain, you have to ask leading questions and elicit these points from the history. So the first thing, it could be, need not be like swallowing difficulty. Swallowing difficulty you get when there is a mechanical compression to esophagus. To reach that stage, the thyroid swelling should be huge enough to cause a mechanical compression of the esophagus. So mostly what the patient will be complaining of will be a kind of something sitting in the throat or foreign body sensation in the throat. So this is what usually the most patients will say. A sense of or a foreign body sensation, or something, some uncomfortable or discomfort in the throat. May not be actual dysphagia like you describe in textbooks. That you get only in advanced stages of malignancy or very large goiters. Otherwise, it will be a sensation of foreign body sensation or feeling of something sitting in the throat while swallowing. Then later on, advanced goiters can cause, long-standing goiters especially, can cause tracheal compression symptoms. Now, tracheal compression symptoms, most commonly it will be recurrent cough. We have seen many, we ourselves had a study here which shows that long-standing goiters can cause, can result in persistent cough or like cough which is not responding to treatment. So that is one of the earliest symptoms of tracheal compression. So patient can have recurrent cough. They will be going on from one doctor to the other, and one of the cause could be a long-standing thyroid swelling. So recurrent cough is one of the methods or early manifestations of tracheal compression. Then Later on, no, when the thyroid enlarges, it can compress the trachea. So when tracheal compression occurs, the lumen narrows. So the lumen narrows, what happens is, it is not breathing difficulty that the patient experiences. Rather than that, it will be dyspnea on exertion. So when the patient exerts, the trachea has to expand and then let in more air. This won't happen if there is a large thyroid swelling sitting on the trachea. So when the patient, so you have to ask for any exertional dyspnea or breathing difficulty or discomfort or sense of choking while doing heavy work. Especially when there is a retrosternal goiter, some patients can complain of discomfort like while like doing cleaning the floor, stooping down, etc. Discomfort can be there. Also, like when they raise the hand, like when they try to hang the clothes in a dryer, when they raise the hands above the level of the head, they can have discomfort. So these are particularly relevant for retrosternal goiters, these kind of discomfort or tracheal compression symptoms. Then sometimes, retrosternal goiters especially, they can result in difficulty in lying in the flat position. So if you ask many patients with a large goiter, see, how do you sleep? Are you sleeping in the flat position, or do you sleep in a particular position, or do you get up from sleep at night? They might tell you that I cannot lie flat. After 10-15 minutes I have to get up, or I prefer lying on one side. Now suppose there is a large nodule on the right side pressing the trachea, the patient might prefer to sleep on the right side so that the tracheal compression is a little bit relieved. So all these are little bit pointers as to the type of tracheal compression the patient can have. So when you look at the associated symptoms, first of all, you look for pressure effects on the esophagus, pressure effects on the trachea. Later on, you can get pressure effect on the, compression or invasion of the recurrent laryngeal nerve can cause voice disturbances. So long-standing benign goiters usually never causes voice change, but we have seen some cases, sometimes voice change you can get in benign, but theoretically for your purpose, for exam point of view, benign goiters will never cause voice change. So when there is a malignancy, this malignancy invades the recurrent laryngeal nerve rather than pressure effect, rather than causing pressure on the nerve. So it will be invasion of the nerve by the malignancy of the thyroid that causes voice change. And what will be the nature of the voice change? This voice change due to thyroid invasion of the nerve by a thyroid malignancy is persistent. It won't be transient. See, the commonest cause of voice change is upper laryngeal or throat infection or an URI, something like that. But if it keeps on recurring, or if it is persisting, or if it is worsening, you have to attribute the voice change to the thyroid swelling the patient is having. So you ask for persistent voice change, not recurrent voice change or transient voice changes. So persistent voice change is the other thing. So in associated symptoms, you ask for pressure symptom on the esophagus, pressure symptom on the trachea, and voice change due to infiltration of the recurrent laryngeal nerve. So once you focus on this, the next thing that you should focus is on the functional aspect of the thyroid gland. Symptoms suggestive of functional status of the thyroid gland, like whether the patient is hyper, whether the patient is hypo. Hypo and hyper can cause a wide range of symptoms in a patient. You have to ask most of the symptoms whether you have this or not. All these things you have to ask. But when you present, you just bring out the salient points only. All hyperthyroid features need not be highlighted. Mainly, like, you ask for heat intolerance, mood changes, behavioral changes, sleep disturbance, loss of weight, then increased frequency of stools. Rest of the symptoms, if somebody is telling you as pronounced, then you can come. Palpitation, again, one of the other main important symptom of hypothyroidism. So when you say the symptoms, you don't have to bring in everything, even though you can ask, but then bring in only the salient symptoms like heat intolerance, palpitation, loss of weight, increased frequency of stools, menstrual disturbances, and emotional or mood changes. Now coming to hypothyroidism, you ask for weight gain, lethargy, sleepiness, fatigue, and constipation. So these, and hair loss maybe. So these things you can highlight. Okay. So in history, like your onset, the progression, pressure symptoms on the nerves, as well as the history suggestive of the functional status of the thyroid gland. Then when you go to the past history, all other medical and surgical conditions this patient is having, you should highlight in the past history, like hypertension, diabetes, coronary artery disease, if there is an elderly male, any prostatic disturbances, any bladder outlet obstruction symptoms, all other medical, any RTAs, everything you should highlight in the past history. Suppose this is a patient who has undergone a thyroid surgery in the past, you should mention that in the history of presenting complaint. Like you start like this patient underwent, so and such patient underwent thyroidectomy 15 years ago. Now for the last 5 years, patient is noticing a swelling. So if there is something relevant to the history of presenting complaint, to the system which you are examining, you bring that out in the history of presenting complaint. All other unrelated medical, surgical, including accidents, body ache, pain, hypertension, all other things you bring out in the past history. When you say about the past history of thyroid swelling, one thing that you should positively ask is for history of irradiation to head and neck region, history of irradiation to the head and neck region in the past, as well as any background irradiation. Now somebody is coming from like the Kollam Chavara area, there the background irradiation is highest in the country. So that is, there are studies saying that the incidence of PAPSI, including other cancers like breast cancer, is higher in that Chavara area. So that thing you can focus when you ask about the geographical position or situation of the patient. Otherwise, you have to ask for history of head and neck irradiation in the past, like children with lymphoma, children with brain tumors, they might have undergone cranial RT before. So suppose such a patient develops a thyroid nodule afterwards in the like 30s and 40s, even if on evaluation it appears benign, you are justified in doing a thyroidectomy because of the history of past head and neck irradiation. So history of head and neck irradiation in the past you should bring out in positively in the past history. Now rest of the history is like family history. Sometimes family history, patients coming from endemic areas, many of the family members can have thyroid swelling, like father can have, some other relatives. This is for endemic goiters. Otherwise, there are rarely familial thyroid cancer syndromes, especially for medullary cancer. Thyroid cancer transmitted from parents to offsprings. So there is this multiple endocrine neoplasia as well as the familial thyroid cancer syndromes, where there can be multiple members in the same family affected with thyroid cancer. So you can bring out all those if it all is there in the family history, and you keep in mind that people coming from endemic areas, many other family members can have thyroid swelling, So all this bring out all this in the family history. Drug history, treatment history, etc. All this you should highlight. Many of these patients will be on thyroxine from outside because it is a over the counter prescription. So whenever there is a thyroid swelling, a GP will prescribe a thyroxine. Thyroxine is helpful in the initial stages of development of a multinodular goiter, like in the hyperplastic stage, before the nodule develops, thyroxine can suppress the nodule formation to some extent. But once nodule forms, there is no role for thyroxine. But we see that many patients will be on thyroxine from outside. So drug history you have to ask carefully and then bring it out. Now coming to examination, you have to focus on general examination first. General examination is a head to foot examination, whether it is pediatrics, gynecs, it's a head to foot examination of the patient, and bring out all the positive as well as the negative points. One thing that for thyroid examination, how we used to do is, we, like every other case, we do the general examination, there's pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy. You have to focus on the pulse rate, whether it is regular, whether the cardiac rhythm is normal, whether there is a radiofemoral relay, whether there is a collapsing pulse. See, thyrotoxicosis, untreated thyrotoxicosis, such cases we don't see nowadays, but you can have a collapsing pulse for untreated thyrotoxicosis. Patients can have atrial fibrillation, so irregular pulse rate can vary. So all this you have to focus on the pulse rate, and the pulse aspect should be described in detail when you say the general examination. Okay, now going to the local examination, I think I'll call a volunteer and demonstrate how to go about local examination of the neck. So we'll proceed with the examination of thyroid swelling. So as you know, any swelling, we have 4 aspects of examination: inspection, palpation, percussion, auscultation. Now coming to inspection, now we have Mr. Prashant with us, who has volunteered to be the patient for your sake. So a big thank you to him. He is our emergency medicine technician. Okay, so Prashant basically doesn't have an enlarged thyroid swelling per se, but I can demonstrate. See, when you examine, so if you go through the DAS, it will be written that the patient will be sitting and examiner sitting, and the patient will be facing you. So you inspect the neck. So in the neck, on inspection, whenever you examine a swelling, there are initially the 5 S's should be focused. What are the 5 S's? The site, size, shape, surface, and skin over the swelling. Unfortunately, but fortunately for him, Prashant doesn't have a thyroid swelling. So, but then when you inspect the site will be front of the neck. Sometimes you might find a bulge on the side. So you say that there is a swelling front of the neck more to the right side, or swelling front of the neck more to the left side. So that is the site of the swelling. Size you have to roughly measure by the inspection, by your eye, by your look. By when you look, what will be the roughly the measurement? The horizontal as well as the vertical dimension of the swelling, you have to roughly say it is about 5 centimeter, 6 centimeter, or like that. The dimensions, the inspectionary dimension of the swelling, you mention. Then the surface, see, there are 3 types of surfaces for any swelling. 3 or rather 4 surfaces. One is diffuse. Diffuse means it's totally soft, nothing, no irregularity. You just see a uniform bulge like the surface of a lipoma. So that is called the diffuse swelling. Next is nodular. Nodular means you find multiple nodules on the swelling over the surface. Sometimes one of the nodule may be bigger. So you say that the surface appears nodular, but there is a larger nodule on the right side. Now sometimes it will be very large, like say 10 centimeter swelling, and you find like a wavy kind of irregularity on the surface. So that is what is called as a bosselated surface. Thyroid swelling, generally the surface will be nodular, but rarely you can get large swellings with a bosselated surface. So size, shape, surface, and the skin over the swelling. Skin over the swelling, you focus on any scar, any discharging sinuses, plus as far as the thyroid is concerned, you look for any dilated veins. Now dilated veins, can you focus here? Look. If you slightly focus, you can see mostly the external jugular vein will be seen here. So this external jugular vein, unless there is a retrosternal extension, you won't, even if there is a retrosternal extension, a lot of dilated veins as described in the textbook may not be seen. But if you focus on the external jugular vein, you can elicit what is called as the Pemberton's test. So how do you do the Pemberton's test? So this is again part of the inspection of the thyroid. First you look at the size, shape, surface, skin over the swelling. Then there are tests specific to the thyroid swelling, that is movement with deglutition, or the swelling moving up with deglutition. Then whether the swelling is if it is a midline swelling, you have to verify whether it is moving up with the swallowing, not only with swallowing, whether with the protrusion of the tongue, and then the Pemberton's test also you have to say. So movement with deglutition, you ask the patient to swallow, see whether the swelling is moving up. The swelling should move up on deglutition. You can slightly, there is a small swelling here. So when swallowing, the swelling moves up. And when the swelling moves up, one more thing you should be careful. You see whether the lower border of the swelling is seen on swallowing. On swallowing, whether the lower border is also clearly seen. So that is one area, one thing that you have to focus when you look at the movement with deglutition. Next thing is movement with protrusion of the tongue. Now movement with protrusion of the tongue, okay, just open the mouth, open. You then ask the patient to put out the tongue and simultaneously you look at the nodule. Now on the you can see now when the tongue is protruded out, you can see the slight movement of the swelling. There's a small swelling seen here which is moving up. Now yes, yeah, okay, sure, thank you. Then Pemberton's test. Now Pemberton's test, how do you do? You have to ask the patient to raise his or her arms above the level of the head so that the arm touches the ears. Kai രണ്ടൊന്ന് പൊക്കാവോ? അങ്ങനെയല്ല, കൈ മുകളിലോട്ട് തലയ്ക്ക് മുകളിലോട്ട്. Arm should touch the ears and keep like this for a minimum of 30 seconds. And when the patient does that, you have to look at the face for any facial congestion. And also I told you there will be external jugular veins will be there. You see whether the vein is getting more prominent or not. So that is how you look for Pemberton's test. The arm should touch the ears as well as you should keep the position, keep in that position for minimum of 30 seconds. Okay, thank you. Now suppose there is a significant retrosternal extension, patient won't be able to hold the hand up like this for long times. That you have to be careful. So inspection, you look at the size, shape, surface, skin over the swelling, whether the swelling is moving up with deglutition or not. Now if it is moving up with deglutition, see whether the swelling is moving up with the protrusion of the tongue as well. Then you look at the Pemberton's test. Now when you look into the when you read through DAS, there is a test called Pislo's method described. Now this Pislo's method is not needed for every person. Now suppose the patient is a short-necked obese person and on inspection the thyroid is not clearly seen, you can employ the Pislo's method for making the gland more prominent so that thyroid gland is made more visible. So how is it done? Pislo's test, Pislo's method of inspection. You ask the patient, ask the patient to keep the hand on the occiput, thala vandu back leg idilottu press cheyana. So when this is done, the front of the neck becomes more prominent and the thyroid gland becomes more prominent. Thank you. So this is how Pislo's method is done. Not to be done in every patient, only if required. Only if required. Suppose the patient is obese, short neck and thyroid gland is not seen on routine inspection, you can employ Pislo's method to make the gland more prominent. Okay. Now going to palpation. Now palpation, you start with local rising temperature, tenderness. Okay. So always make sure that there is no local rising temperature or tenderness. So that is the first thing that you have to be careful. Once that is made sure, thyroid gland is palpated with the neck held in semi-flexed position, not fully flexed or not extended. It is in the semi-flexed. By this is how you put the position of the neck, semi-flexed position. What is the purpose of that? The purpose of palpating in semi-flexed position is to make the fascia and the neck muscles relaxed so that the gland is easy to palpate. Now this is the classical method of palpation. The fingers meeting in the midline at the nape of the neck, the thumb meeting at the nape of the neck, and with the fingers you palpate from behind. So the examiner will be standing behind and the patient will be sitting and thumb meeting at the nape and with the fingers you palpate the surface of the gland. And while palpating, you ask the patient to swallow. Yeah. When this is done, so this is how palpation is done. So when this is done, the nodule will slip underneath the finger. When you ask the patient to swallow, the nodule will slip underneath the finger and you can appreciate the surface of the gland more clearly. Now suppose you want to palpate this side more clearly, you can ask side. Yeah. You can ask them to tilt their head to one side so that the fascia and the muscles are relaxed and you can palpate the other side more clearly. Also if you want to palpate this side, you ask the patient to tilt the head to the other side. Okay, so that is how palpation. We start with local rising temperature, tenderness. There is a semi-flexed position of the neck. Then you ascertain, once again you verify your inspectory findings of size, shape, surface, skin over the swelling. Make sure that the gland is moving up on deglutition on palpation. Palpate the surface clearly. Palpate all the borders, especially the lower border. You should palpate. Make sure that now when you feel, if you're feeling the trachea clearly at the lower part, that means the lower border is palpable. The upper border, lateral borders may be difficult to palpate because the lateral border goes underneath the sternocleidomastoid. So all the borders you should palpate, the surface, and then the consistency. The consistency you press and see whether it is a firm, hard. If it is hard, whether it is bony hard or stony hard, or whether it is a soft swelling. So palpation wise, all these areas, all these things that you have to measure, you have to verify. Then in DAS there are additional methods of palpation described, that is to help you in understanding the nature of the thyroid swelling in very particular situations. One is Lahey's method of palpation. Lahey's method of palpation is, now suppose there is a nodule on this side, right side alone, and you are not very sure whether there is a nodule on this side, then what you can do is, in Lahey's method of palpation, you press the neck from the opposite side, so that this side, the gland is made prominent and you can palpate the other lobe more clearly. So to make the other lobe more prominent, you can press from the opposite side and then you palpate, so that you can verify whether there are nodules on the other side, and also the posterior border, which is usually underneath the sternomastoid, will also be lifted up. So that is the advantage of Lahey's method of palpation, to understand a particular lobe more better, whether it is soft, whether there are any small nodules which are not felt on routine palpation is there. Next is the Kreil's method of palpation. Now Kreil's again is to distinguish whether the surface of the gland is diffuse or is it nodular. That helps to identify fine irregularities on the surface. So it is done like that. Kreil's thumbs are kept at the front and patient is asked to swallow. Yeah. So this is how it is done. Then you find that the gland will be moving underneath the thumb. So fine irregularities you can palpate. Then should be followed by examination for any other swellings of the neck, as well as the carotid pulse. Carotid pulse is felt. So this is the upper neck crease, anterior border of sternomastoid, and here, this is the point where you have to look for common carotid pulsation. The pulse is palpated from behind. Most of the neck swelling, including the lymph nodes, are palpated from behind. You palpate here for the common carotid pulsation. So anterior border, upper neck crease, the junction, you palpate for the carotid pulse. Never palpate carotid pulse simultaneously on both sides. It's palpated one at a time, one and then this side. See whether it is felt in the normal position, or whether it is absent, or whether it is displaced posteriorly. Displacement of the posterior, you find the pulse here. So large swelling can displace the pulse posteriorly. Then rather than at the anterior border, you might feel the pulse at the posterior border. Thank you. So I hope you understood how palpation is done. So you focus on the inspectory findings, confirm the inspectory findings, plus you have to palpate the surface, make sure that the lower border is felt, the consistency, then followed by the carotid pulse and any other swellings like enlarged cervical lymph nodes or any other swellings are palpable. Now palpation is followed by percussion. Percussion is done on the sternum, and if the percussion note is dull, it means that there is some retrosternal extension of the gland, followed by auscultation. So percussion, auscultation is done. You auscultate the upper pole of the thyroid gland for any thyroid bruit. Thyroid bruit you get in hypothyroidism, so thyrotoxicosis. So you palpate or auscultate the upper pole for any thyroid bruit. Also, you can use the auscultatory method to make sure that the trachea is central. Now, in tracheal deviation, in palpation, now sometimes there is a big swelling sitting in front of the neck. You won't be able to palpate the entire trachea, because especially when there is a midline swelling, the trachea won't be palpable because of the thyroid swelling. So the best method to ascertain position of the trachea is auscultation. So you auscultate at the midline and then you auscultate on either sides and make sure that the trachea is in the central. So when you auscultate, you will get the bronchial breath sounds, and auscultate on the right side, auscultate on the left side. See where you are getting the bronchial breath sounds maximum. So that will get you will tell you the position of the trachea. So likewise, you go ahead. So inspection, palpation, percussion, auscultation, auscultate the thyroid for any bruit and also for any and also for any tracheal deviation. So at the end, and then followed by when you are done with the local examination, this should be followed by 2-3 specific systemic examination findings as far as the thyroid swelling is concerned. One is eye signs. You have to focus on the eye signs, say whether eye signs are present or not. Then skull and spine, because follicular carcinoma of the thyroid follicular carcinoma of the thyroid can cause metastasis to the skull, metastasis to the flat bones. So skull and spine you should specify, and also Horner syndrome. Large thyroid swellings, sometimes pressing on the carotid, can affect the sympathetics on that side. So it can even cause a Horner syndrome. So how we used to say is, like at the end of, after general examination, the inspection, palpation, percussion, auscultation of the thyroid gland, and before I go to the general systemic examination, I'll say that there are no eye signs, there is no Horner syndrome, skull and spine normal. So these 3 things you have to specify. Either you can say this along with the general examination or at the end of the thyroid examination. So I prefer to say it at the end of the thyroid examination, after you finish the inspection, palpation, percussion, auscultation, no eye signs, or if eye signs are there, describe that. Skull and spine normal, there is no Horner syndrome. Followed by general systemic examination of all the systems. Suppose it is a hypothyroid patient, make sure that you do a knee angle jerk, knee jerk and angle jerk, and look at the relaxation time, because hypothyroidism, one of the clinical sign that you can elicit is a delayed relaxation time of the angle jerk. So you should have your knee hammer with you. Look at the angle jerk time, look at the skin turgor, look at whether there is a non-pitting pedal edema. So all these things you do along with the general examination, or specifically look for all these things, all these signs at the end of the local examination. And once you are done with the examination of the thyroid, your diagnosis should come. It should be like one, the components. When the class started itself, I told you like how to go about wording the diagnosis of thyroid. Once again, I'll say that at the end of the examination, your diagnosis, it should go like case of a thyroid swelling, multinodular goiter, clinically benign, no hyper or hypothyroid signs, or functionally euthyroid status, no retrosternal extension. So likewise, thyroid swelling, whether it is a solitary nodule or it's a diffuse goiter or a multinodular goiter that you have to mention, whether it is benign or malignant clinically, you have to say. To say that it is malignant, in the history, you could get a history of a voice change, or on palpation, or there is a history of a recent increase in size, or on palpation, there is hard nodule felt, or 1 or 2 lymph nodes are palpable. Then you can consider the possibility of malignancy in the diagnosis. So likewise, so whether it is benign or malignant, followed by functional status of the gland. What do you think clinically the functional status is, whether it is euthyroid, hyperthyroid or hypothyroid, followed by like whether there is any retrosternal extension or not, because all these things will decide the management. If suppose there is retrosternal extension, even if it is benign, we might suggest surgery. So all this can influence your management. So you have to bring out all these components as aspects of thyroid swelling in the diagnosis. And the diagnosis doesn't stop with the thyroid swelling alone. All other diagnoses, suppose the patient is hypertensive, diabetic or anemic or bronchial asthma, all this you should bring as 1, 2, 3, 4 in the diagnosis of the patient. It should not be Raghavan with a thyroid swelling. If the Raghavan has hypertension, you should bring that as a second diagnosis in your list, in the diagnosis of as far as that patient is concerned. It not only the thyroid swelling, patient is a hypertensive for 10 years, diabetic for 6 years, patient has got bladder outlet obstruction, or patient is asthmatic, history of coronary artery disease, all these things that you have to mention in the diagnosis. Now once you come up to this stage, before you come to the diagnosis, you have to give a short summary of relevant points in the history as well as the physical examination, and then come to the diagnosis. And once you come up to this stage, it's followed by the discussion. Discussions will depend on like the examiners, but then there is a general pattern of discussion for a thyroid swelling as far as undergraduates are concerned. So the first question will be like, usually, why did you make the diagnosis of a multinodular goiter? Or why did you make the diagnosis of a malignancy in this case? Or why did you make the diagnosis of a goiter with retrosternal extension in this case? So you have to bring out with the points. Why do you think that it is a malignant? Why do you think that it is not malignant or retrosternal extension? So the points suggestive of malignancy in the history are: one is a history of a recent voice change or recent increase in size. On palpation, you can get a hard nodule or a nodule with a slight fixity or presence or absence of lymph nodes. Not absence, presence of lymph nodes. So if all these points are there, or any one of these points are there, you can consider the possibility of a malignancy. Or a palpable, there is a solitary nodule right lobe is there, which is slightly hard in consistency, and there is a 1 week duration scalp swelling. You can very well consider the possibility of a follicular carcinoma of the thyroid. So likewise, they might ask you why you are saying this particular diagnosis as the most probable in this patient. So you should be ready to explain why you are saying that. Now once that is done, usually we go about like how do you proceed with the case. So investigation of a thyroid patient. So investigation, generally this is the case of a swelling, a thyroid swelling. So generally we start with the thyroid function test. Thyroid function test, which is the normal value you should be knowing, the free T4, T3 and the TSH, and the interpretation of thyroid function test, how it goes, what are the normal values, all these things you should be knowing. So once thyroid function test, the other general examination, general blood test can be done. Then for evaluation of thyroid swelling per se, we start with imaging. We start with the ultrasound of the neck. Then again it varies from case to case. Suppose there is a large, very huge thyroid swelling which is infiltrating trachea or infiltrating the carotid vessels, we might need additional higher imaging, but you always start with the ultrasound of the neck when you start evaluating a thyroid swelling. So ultrasound, what is the thing that we are looking for in ultrasound? We are verifying the nature of the swelling, whether there is any malignant focus in ultrasound, whether it is totally benign. How will you look for malignancy in ultrasound? So ultrasound, a malignant nodule will appear very dark or hypoechoic. It can have calcific spots inside, which is otherwise called as samoma bodies, or there can be vascularity to a nodule. Nodule can have a the vascularity inside, and also perinodal vascularity can be there, and there can be suspicious lymph nodes can be there in the surrounding. See, if all these features are there, we might suspect ultrasound, imaging wise, radiologically, we might suspect malignancy. So that is the purpose of imaging. You look at the nodule, assess the characteristics of the nodules of a thyroid swelling, then look for any lateral lymph nodes. If there are suspicious lymph nodes, again the possibility of malignancy has to be considered. So once imaging is done, then it is followed by cytology, FNAC. Now, what is the purpose of FNAC? FNAC, the purpose is to know the nature of the nodule or nature of the thyroid swelling. Now, there are certain conditions which can be diagnosed by FNAC as far as thyroid swelling is concerned. One is all benign conditions like multinodular goiter or benign nodule or colloid nodule, thyroiditis can be diagnosed by FNAC. Malignancy, you can diagnose papillary cancer by FNAC. You can diagnose anaplastic cancer by FNAC. Medullary cancer, you can diagnose to some extent by FNAC. And lymphoma of the thyroid also you can diagnose by FNAC. The only one tumor which cannot be diagnosed or condition which cannot be diagnosed to 100% by FNAC is follicular cancer of the thyroid. So this is a favorite question for exam. Why is it not possible to diagnose follicular cancer by FNAC? Almost all conditions, all benign, papillary cancer, medullary cancer, anaplastic cancer, lymphoma, it can be diagnosed by FNAC, but follicular cancer cannot be diagnosed by FNAC. The reason is, when you have to say, to make a diagnosis of follicular cancer, you have to demonstrate invasion of the cancerous cells to the capsule, that capsule as well as to the vessel. That is, we call it as vascular invasion as well as capsular invasion. Invasion of the capsule of the nodule by or breach of the capsule by the cancer cells, or invasion of the vessels by cancer cells. Now these two processes we cannot diagnose by FNAC. So to diagnose follicular cancer, FNAC is not enough. We only get the diagnosis as a follicular lesion or a follicular lesion with of atypical, undetermined significance, follicular neoplasm. So this is the diagnosis that we get on FNAC. Then we go ahead with surgery, and follicular cancer is usually a post-operative diagnosis. Diagnosing follicular cancer with FNAC pre-op is not possible, because to diagnose a follicular cancer with diagnose a follicular cancer, we need to demonstrate either a vascular invasion or a capsular invasion. This is not possible to diagnose by FNAC. So all other conditions except follicular cancer can be diagnosed by FNAC. So that is how the evaluation goes. So if ultrasound followed by FNAC. Now suppose the initial thyroid function test when we do, if it is not U or hypothyroid, or rather if it is showing hyperthyroid state, then there is one more additional test that we do. In hyperthyroidism, now we have to know the reason why it is hyperthyroid. Hyperthyroidism means the gland can be hyperactive, producing more thyroid hormones, resulting in hyperthyroid symptoms. So hyperthyroidism can be due to many causes. It can be thyroiditis, resulting in release of more thyroid hormone into circulation. It can be primary thyrotoxicosis like Graves' disease, because of increased production from the gland. Or it can be secondary thyrotoxicosis like a long-standing goiter developing hyperactivity in the internodular areas. So we need to differentiate which is what causing hyperthyroidism, so that then the management can be planned. The treatment for each of these conditions is different. So it is essential to differentiate whether it is a thyroiditis causing the hyperthyroidism, or is it primary thyrotoxicosis, or is it secondary thyrotoxicosis. How do we know that? We know that so if there is a hyperthyroidism by blood evaluation, we have to do a diagnostic nuclear iodine scan, diagnostic radioiodine scan. So it's a iodine scintigraphy, rather we would call it as thyroid scintigraphy, not iodine scintigraphy, a thyroid scintigraphy. Now thyroid scintigraphy, for diagnostic purpose, the material that we use is technetium-99. It is not iodine scan. Iodine scan is done for papillary cancer after surgery. For diagnostic purposes of hyperthyroidism, we use a technetium-99 scintigraphy, and with that we will be able to differentiate whether it is thyroiditis or secondary thyrotoxicosis, or is it a Graves' disease by the pattern of uptake. So once that is, so hyperthyroidism, we need to have this. Okay. So then I think management of each condition of thyroid itself is a big topic. So you need to know, like when you come up to this level, like the evaluation, FNAC and all those the imaging, what do we do, and all those. Generally one favorite question will be, what are the indications for surgery for thyroid? What are the indications? Because it is a surgery examination, they might ask you, when will you operate on a thyroid, or what are the indications for surgery on a thyroid? So the indications for surgery for thyroid are very simple. One is benign goiters with pressure symptom. So a benign goiter with pressure effect on the trachea, esophagus, or the esophagus. So any benign goiter with pressure symptom. A goiter with a retrosternal extension. Third indication will be a goiter with suspicion or proof of malignancy. Now suppose there is a suspicion of a malignancy by imaging, or suppose FNA says that it is a malignant process. All these things are indications for thyroidectomy. So a benign goiter with pressure symptom, a goiter with retrosternal extension, a goiter with suspicion of malignancy, a goiter with proven malignancy, then a goiter with a secondary thyrotoxicosis. So these are the indications for thyroid surgery, broadly speaking. Then they might ask you, like, what are the thyroid surgeries that you are aware of? So usually for malignancy we do a total thyroidectomy. So there is nothing like a near total thyroidectomy. It's always a total thyroidectomy or a hemithyroidectomy. So what is the total thyroidectomy? What is a hemithyroidectomy? There is a term called near total thyroidectomy also. I think we can have a discussion of all these things, the management of thyroid nodule per se, in another class. Now, thank you for listening. Thank you for the time being. Thank you.